Len-refractory patients have poor outcomes. So we are here at ASCO to talk about one study with perhaps a new option for these patients who are lenalidomide-refractory in the setting of relapsed multiple myeloma. And to do that, I am talking with Dr. Ajai Chari, who is an associate professor and, more importantly, he is the director of clinical research in the multiple myeloma program at Mount Sinai. So this is a subgroup analysis, and we need a reminder first off of the group that this is a sub of, and that is MMY-1001, what it was and what it found.
Sure. So MMY-1001 is basically a phase 1 study where the CD38 monoclonal antibody called daratumuab was combined with various backbone regimens, including, for example, bortezomib and melphalan, lenalidomide, pomalidomide. And so this particular combination arm was with carfilzomib. And the subgroup analysis is specifically in patients who were treated with DARA, carfilzomib, and Dex, those patients who were Len refractory.
So in the original study, DKD induced deep responses and was well tolerated.
Correct.
And so now you wanted to look at the Len refractory patients. So in this analysis being presented here, what are you presenting?
So I think the reason this is so important is because there were 4 high-impact phase 3 publications in myeloma, all of which showed benefit with the novel agent, but the control arm was RD. So while those showed improvement, the problem is if more and more patients are getting lenalidomide maintenance, right, who are those Len-sensitive patients that are not really happening? And so when you have these phase 3 studies, the outcomes may not be generalizable to that patient sitting in front of you in clinic who's Len refractory. So this particular analysis was to look at patients who are lenalidomide refractory, because that here should not affect the outcomes theoretically, because the novel agents are daratumuab, carfilzomib, and Dex. Right. So a priori, you wouldn't necessarily expect a requirement that Len refractory nirsevimab might change the outcomes. So what we showed is of the entire cohort of approximately 80-something patients, half or 50 patients or so were Len refractory. And what we find is that the safety was no different. Importantly, we did a slight tweak of previous DARA in the 1001 study, because this study, the daratumuab was given as a split dose, because normally it's given as a full infusion on day 1, which can have a median of anywhere from 6 to 8 hours of infusion, which can be challenging in the community practice. Here, it's split into 2 days, so that day 1 and day 2, daratumuab is given, and then carfilzomib is given weekly at 70 milligrams per meter squared. So I mention that because in addition to not seeing any difference in safety from what you would expect with individual agents, and notably there was a relatively low rate of grade 3-4 neutropenia, only about 20%, which is important because in the relapse refractory population who have a heavy marrow burden, using myelosuppressive agents can get you very high rates of neutropenia, and infections are one of the most common causes of morbidity and mortality. So expected safety, nothing unusual. The split dose was very effective in the sense that the rates of infusion-related reactions were about 37% on the first day and only 4% on the second day, so very low. And the median infusion time in each of those days was approximately 4.3 hours, which makes it more manageable for both patients and physicians in the community practice. And then in terms of the efficacy, actually, going back a second, the PK also was no different when you did the split dosing or the full 1 day. So at the end of the 1-day PK DARA versus the end of the second day of infusion, the pharmacokinetics of daratumuab were comparable. So all of that, I think, is important. And the efficacy was interesting because I think the response rates were no different in Len refractory versus the overall population. The response rate was approximately 80%, including about 20% of CRs and stringent CRs combined. So that's very exciting, even some minimal residual disease or MRD negative patients. And I think perhaps the most interesting thing is the progression-free survival of DARA in Len refractory patients, of DKD in Len refractory, was about 14 months, which is really impressive. When we look at the limited data of published or presented studies, POM-DEX by itself only has a PFS of around 4 months. And then several other studies, DKD, DPD, and also KD, all of those have a PFS of around 8 to 9 months. So while we can't compare directly across studies, I think 14 months is very encouraging for PFS in a Len refractory patient. And the median OS was approximately 18 months for this population. With, again, follow-up needs to be longer. It's only median of 12 months of follow-up. But I think that's what's exciting about this data, that it gives us yet another option for patients who are Len refractory. And probably lastly, DARA has already been approved now in 5 different combinations as a single agent, in combination in relapse disease with bortezomib and lenalidomide, in the US also approved in combination with POM, and just recently was approved in a newly diagnosed patient with bortezomib, melphalan, and prednisone. And as we know, every patient has a certain risk-benefit profile for a given drug, and to be able to combine monoclonal antibody like CD38 with carfilzomib, I think is exciting for patients to have yet another option to use DARA, especially in this len-refractory population.
Are you going to be using this now in clinic, or do you think there's a need for more data?
Because these are 2 active agents, and because monoclonal antibodies historically haven't added a lot to toxicity, it's similar to Rituxan, has been added to many different regimens. So similarly, I think what we're seeing with DARA, and that essentially was the purpose of 1001, is to see the safety profile of DARA added to these. And because we don't really see a change in the toxicity profile, I think for patients who are refractory to lenalidomide, we have already been using this extensively in clinic. If we could get insurance approval more readily, I think that'll be the main reason to get additional data. But there are 2 large randomized phase 3 studies going on with daratumuab. One is with carfilzomib, so KD plus minus DARA, and the second is POM-DEX plus minus DARA. And those will give the definitive data for these particular combinations. But in the meantime, I think there's a dire need for combination therapies in the relapsed refractory population.
I didn't ask, was there a specific definition you used for refractoriness?
So len-refractory is typically defined as is per IMWG criteria, which is progression on or within 60 days of therapy.
Okay. So you're optimistic at this point?
Yes, I think it's another exciting option.